I think let's move on to the next speaker. I think now we'll really switch on to the overall theme into a case profile. I think the next speaker is going to be Dr. Vardhaman Kankaria. And to introduce him, I request Dr. Fairoz, our dynamic scientific member. Over to you, Fairoz. I'll be just sharing you the screen
Thank you,
share.
Dr. KP. So far, it's going so fantastic. And it's been a pleasure listening to all the experts on refractive surgeries. So I take this honor and pleasure to introduce Dr. Vardhaman Kankaria, who is a very young, vibrant, excellent cornea refractive surgeon that I have known right from his, post-graduation days. And he has been the recipient of various awards, and in most of the international and national front, he has made us always proud in the excellent talks that he delivers and the scientific content with which he presents his paper. So you have always made us proud, Dr. Vardhaman, and to his credit, he's a recipient of various awards nationally and internationally, and he's a great orator as far as I know. So, welcome, and it's a pleasure to have you with us, Dr. Vardhaman. Over to you for your talk. Thank you so much.
Thank you very much. Thank you so much, Dr. Fairuz, for kind introduction. And once again, I'll just put my slide on. Yeah. Thank you. So I'm going to keep it quick. First of all, thank you, Dr. Partha sir and Dr. Kudlu for this kind invitation. I'm just going to speak about one of the ways to perform both LASIK enhancement and some experience with that. So we all know that LASIK has been probably the most popular refractive surgery world over, right from its beginning until even today. And of course, compared to its prior preceded, which was surface ablation, it actually definitely provided us a lot of advantages, and those advantages were because of the intrastromal ablation. Now, of course, with the advent of SMILE, which is now probably one of my procedures of choice, we have gotten away into a flapless LASIK era. However, when we talk about primary LASIK patients who have been treated in the past, and some of them do require enhancement, from very early days till until now, I think the enhancement rates are now gradually decreasing because we have a better patient selection criteria and also probably the better laser profiles. However, still the retreatment rate for residual refractive errors as well as for regressions are there. And currently there are chiefly three approaches that we look at. One of them is doing surface ablation, relifting the same flap, or even cutting at deeper level with the femtosecond laser technology. And when we look at the surface ablation, of course, it is one of the simplest ways to enhance a patient. One of the other things that we have to look at is that possibility of phase formation is much higher. If you do surface ablation, you have to use mitomycin C for much longer time. And the epithelial profile is going to be variable, so you should have access to the epithelial mapping. When it comes to the relief with the flap, it is very crucial that you don't disturb the epithelium around, because this relifting is known to cause increase in chances of DLK, epithelial ingrowth, and also certain instances of having microstriae. And the flap lift are known to be slightly more difficult with the femtosecond LASIK procedure, especially after a long time of the primary procedure. So I'm not dwelling into this case, but this was one of the cases that we had published in which after two enhancements which were done elsewhere in Athens, in Greece, actually this patient had developed very, very high astigmatism because of severe epithelial ingrowth. And we had to actually go and ampute this flap, and then we achieved finally 20 by 30 vision, and we had published some time back this in JCRS. So when we look at this thing is basically because whenever we are looking at flap relift, there is much higher chance of epithelial ingrowth because you are entering through the same side cut which was created in the past. What if you create a new side cut and use a approach which is a side cut only approach to relift the same interface and perform a enhancement? So side cut only approach can be performed with the femtosecond lasers, as you know, and especially what you have to do is that you have to create a flap, and which is going to be only the side cut which is going to be created about 1 millimeter inside the previous flap with the same lamellar interface. So you have to go 20 micron deeper and you have to be 1 millimeter smaller as compared to the previous flap. And you have to make sure that you are actually taking care of marking the previous flap edges very well, because you do not definitely want intersection. So this is one of the videos which actually shows with intralays how this is done. You can see these are the markings of this, and this is the flap which is created inside the previous flap. This is very crucial because now you have two side cuts, as you know, and you have to be extremely careful when you enter this interface because the interface is the same. So in this case, you, instead of going with a small lifting of the edge and going with your spatula all around, you have to actually make sure that you have separated this side cut from everywhere, because there is a possibility if you just enter with a spatula without just making sure that you are erupted a new side cut, you can actually enter from the old side cut from this side. So basically speaking, as you can see, once the side cut is done, this is the old interface which is re-lifted back. And then once the old interface is lifted, you just have to go inside and you have to do your ablation. And once the ablation is performed, you have to put the flap back in its place. And yes, this is the end of the enhancement procedure. Always put a contact lens in such scenarios at the end of the procedure. So as you can see, this is the new side cut inside, and this is the previous side cut. This new side cut with the femtosecond laser is very pristine and has been planned well. This can also be done with the Smile or VisuMax technology if you go and use the Circle software. If you're using the Circle software, the Type 1 module of the Circle software actually has the possibility of creating only the side cut, and in that you can actually perform the same kind of side cut approach. So we have treated about 11 eyes with this approach with a mean age of 30 years and with a mean corneal thickness which ranged to about 480 microns in this case, and mean pre-enhancement refractive error of minus 1.86 diopters. So this was the pre-operative spherical equivalent. This is the pre-enhancement spherical equivalent, and this is what has been achieved at the end of enhancement. So this was the further one nice report which I had pleasure of actually collaborating with Dr. Praveen. This was a study which we had done in Basam Palmer with Dr. Sonia Yu, and in that we had actually shown with the same approach, if you have to be very, very careful, because if you actually go eccentric in this case, as you can see, you can induce irregular astigmatism, and this was something that we published in JRS in 2013. So basically, this approach is one of the good approaches if you're looking at enhancing a post-LASIK patient, maybe 3 years or more down the line after the primary LASIK procedure, because it is going to definitely reduce your chances of having especially the epithelial ingrowth. Thank you very much for your kind attention. Thank you.
Thank you, Vardhaman, for this very nice talk. I would request Professor Tatyal. Sir, are you there? Dr. Rupal, ma'am.
Namrata, you can, Dr. Namrata.
Dr. Namrata, ma'am.
I think
A quick comment.
very nice case, Vardhaman, and very nicely managed. A novel way of managing it, and these cases are always tricky. I think Vardhaman did a great job. I can only, appreciate the case that he presented.
Vardhaman, a quick question from my side. That was really very wonderful. Your preoperative refractive error showed -5, and you had showed a residual of -3. -3 as your residual. So how do you account for that? I mean, residual being -3.
Yeah, so basically some of these cases have been actually...
Can we have rest of the speakers to be on the mute mode?
Probably Dr. Right. So yeah, some of these have been actually very, very old cases. Like they are probably older than 10 years or 12 years after the LASIK procedure. And that was like the mean. So basically the primary treatment has been as high as 8 or 9 diopters actually in those cases.
Titial, sir?
Titial, a quick...
Before I make a comment, I would like to ask Vardhaman a very nice presentation of cases. What about the use of contact lens, which is quite controversial now? Some people say you should put contact lens. Some people say you don't put contact lens, and some people do de-epithelialization of area before you lift the flap in these cases. Because as far as I'm concerned, we have done also quite a number of cases where we re-lifted the same flap like we do for routine LASIK. So if you manage the flap appropriately, the chances of epithelial growth is there, but quite less. What about using alcohol near the edge area to devitalize the epithelium?
Sir, I think what you have discussed with your experience is quite true, because the mismanagement of epithelium around the edges of the previous flap is the main reason for epithelial ingrowth. And if that can be taken care of by either denuding a bit of epithelium around it, or whatever way is possible, probably will reduce it. But because right now it is so difficult to actually have a kind of randomized control study, because this thing is so rare. And nowadays the enhancements have become also very uncommon, and we also approach it with surface ablation many times also. So we don't really come to know. But I know from one thing is that Dr. Praveen had done one study in Bascom Palmer that time, in which they compared the relifting of the same flap and versus the side cut only approach in about, I think relifting was done in about 100 odd eyes, and the side cut only approach was done in about 21 eyes. And they had seen that the side cut only approach reduced the epithelial ingrowth rates statistically significantly in that case. But yes, definitely, I think if it is well managed, epithelium around the edges is well managed, it is possible to relive the same flap, especially less than 3 years after the primary.
Can I make a comment?
Parveen, what about contact lens? What's your idea on that?
So contact lens, so I think I personally prefer to put whenever I have a dicey situation, typically speaking. I typically use it, but I think all others can probably find it.
A quick comment from
Vardhaman, can I make a comment?
Yes, ma'am. Yeah.
Ma'am.
Yeah, sorry. Vardhaman, wonderful presentation as usual, what was expected from you. Vardhaman, I just wanted to say that this limits you if you don't have a femtosecond laser. So, and not everybody in India would have one. And therefore, I think it's also good to learn a technique which will give you a less chance of epithelial ingrowth. And it's possible to lift a flap. I've done one even after almost 19 years without any epithelial ingrowth. So it's also better to learn a technique to open the flap. And once you can master it, even if you don't have sophisticated equipment like a femtosecond laser, because this would now again involve you to use a license.
Yeah.
If you're using something like a circle software, right. Only side cut maybe you will be able to do. You may not know exactly the extent of your flap. Sometimes the flaps are decentered and your side cut may not be decentered because you're centering it exactly. So, you can avoid these situations, because otherwise you'll have a wedge at the end.
Right.
If you just can't match it. And therefore, I think it's also good to learn the basic techniques and try to not disturb the epithelium while entering, and you can still do a good job.
Absolutely. Yeah. Completely. Yeah.
Thank you, madam. Thank you so much.